Hi there, I'm Jamie Taylor. Welcome to Your Health Matters, brought to you by Kingman Regional Medical Center, your community-owned hospital. Every week on this program, I have a different guest, and we talk about different programs, services, opportunities in healthcare that I think will be of interest to you and your family. I have an exciting guest on my program today, so I hope you'll stay tuned and join us. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Robert Tucker, who is a pharmacist and the clinical pharmacy coordinator for the pharmacy department. Thank you for being on the program today.
Thank you so much for having me, Jamie.
It's great to have you, Dr. Tucker. We were talking before we started filming today about your background. So you're from Massachusetts originally. And how did you decide to become a pharmacist?
Basically, it was like a process of elimination.
Okay.
Basically, I wanted to be a physician, I really did. But I said to myself, and my dad was sort of in the same line of thinking, that, you know, pharmacists are very, very well respected in the community.
Right.
And I think that that probably would be a better route to have a career in, rather than in medicine.
Interesting.
So
well, it's still medicine,
right,
but just not a doctor.
Yeah, you're just not, right, an MD.
Well, yeah, you are a doctor.
Yeah, and as I said, I pursued that. I enjoyed it. Every year that I've been in pharmacy now for almost 43 years.
Wow.
So it's been very, very beneficial to myself.
Awesome.
And I'm sure I've impacted a lot of people in my 43 years as well.
Absolutely.
Yeah.
Well, and you've seen a lot of changes.
A lot of changes.
In how we do
Oh,
pharmacy.
God, I remember when we used to be in the old counting, pour, lick, and stick mode of practice.
What does that mean?
Basically, where you just get your meds and you mix them all together and you stir them up.
Oh, really?
Yeah.
Just like on the movies.
Yeah, on the movie. And now, of course, it's much more high technology today. And the students today really spend a lot of time studying the pathology of disease processes and the respective therapies to treat these particular pathologic situations.
So it's not just the drugs.
It's not just drugs, exactly.
Okay.
We have so many different modalities in treatment today.
Interesting.
Yeah.
But it all still, it falls under pharmacy.
Yes, exactly, right.
Interesting.
Yeah.
So where'd you go to school? How'd you learn to be a pharmacist?
Okay. Basically, I started out as a pre-medicine major at Providence College in Providence, Rhode Island.
Okay.
And then I switched after my dad died over to pharmacy, because my dad always said it'd be very nice if you became a pharmacist. So I basically went back home to Boston and went to the Massachusetts College of Pharmacy and Science, which is part of the Harvard Teaching Program on Longwood Avenue in Boston. And so I received my Bachelor of Science degree there in 1972.
Oh, very good. That was a good year. I remember that year well.
Yep. And then I said to myself, I said, well, I saw a lot of my classmates applying to graduate school and medical school and dental school, et cetera. And I said, well, with just a bachelor's degree, what could I really do? And I said, well, why don't I think of going into a specialty? And I said, well, I think hospital pharmacy would be nice, because I practiced as a student for 5 years in one of the neighborhood Catholic hospitals. And I really enjoyed it. I liked the patient contact. I liked the nurses, being up on the floors with the nurses, filling their machines, et cetera, with medicines in the olden days. And I said, well, let me pursue a graduate degree. And I went ahead and got a master's degree in hospital pharmacy practice at St. John's University in New York City.
Wow.
And my preceptor was a definite leader in hospital pharmacy practice. Her name was Sister Jane Marie Durgan,
Okay.
and she basically headed up the clinical sciences division at St. John's University, and I was her graduate teaching assistant.
Nice.
And during my 2-year master's program, she would assign me to precepting students at various hospitals in the 5 boroughs of New York City,
Okay.
and also in Long Island.
Wow, so you're in the
And
heart
so-
of it all.
Yes, exactly. And I really I loved the practice, I loved teaching, and I said, I think I found my niche
Good,
in
good.
hospital pharmacy.
Okay.
So I've been in hospital pharmacy now, including my 5 years as a student, approximately 47 years.
Wow.
Yeah.
That's a lot of
So,
time.
a lot of time.
A lot of drugs.
A lot, a lot of hours there, I'll tell you.
Okay, so what brought you to Arizona?
To Arizona,
then?
basically, I had taken my license in Arizona in the year 2001.
Okay.
My mom's health, I lived with my mom
Okay.
for about 58 years.
Oh, okay.
And when she passed away, I said, I think I want to move from the cold climate to a warmer climate.
I can relate to
and
that.
I already
yes.
had my Arizona license, so I basically got a publication which comes out of Madison, Wisconsin. It had all job opportunities. So I immediately went to the area for the West Coast. And I saw Arizona, and I said, I think that'd be great. I got my license there. I don't have to worry about studying anymore.
Right,
As
nice.
far as preparing for any particular exam, I already have the license.
Mm-hmm.
And I said, I think Arizona would be nice. You know, 300
Yeah.
plus days of sunshine.
Yes, I know. I love it.
You
huh?
know, and the weather is pretty temperate year round.
Yes.
I said, I don't have to worry about shoveling any snow.
Yeah.
So I ended up interviewing at 6 hospitals in the greater Arizona area, which include Phoenix, and up here in the tri-state area.
Mm-hmm. Okay, so you looked like
the Tri-City, excuse me,
like
Tri-City
so
area.
Bullhead and
the
Havasu,
Bullhead,
Kingman.
Havasu, and Kingman.
Okay.
And I really, really enjoyed the interview here.
Good.
And the people that I met here were just wonderful. And in the 8 years that I've been here,
I was just gonna ask that.
it has held true.
Good.
Yeah.
That's awesome.
Yeah.
So we've been blessed for 8 years to
Yeah.
have you here. That's
Yeah.
awesome.
Yeah.
And I know that you've talked about the changes you've seen in pharmacy, both I think on the floor as well as mixing. If I
Yes,
don't know
exactly.
what the correct terminology.
Traditional pharmacy.
Yes.
Yeah.
Okay. Because I know we have. Is it Pyxis? Is that what
Yeah, we
they
have the
call?
Pyxis, yeah, dispensing system.
Okay.
Yes, exactly.
How does that work?
Basically, medications are filled
Mm-hmm.
in this machine, and the nurses have sign-ons to get into these machines, and there are profiles of each of the patients in each of the respective units, and basically the nurse goes in and calls up her particular patient, and then she scrolls down to the particular medication she wishes, and then she just basically tabs on it, and the drawer will come out, and it'll open,
Voila.
and she'll take out the particular med that she needs.
So it's based specific on each patient.
Yes.
So when a patient's discharged, then they go away off
They
the
go off
Pyxis
the
system,
Pyxis
and then a
system.
new patient comes
Comes
in, and they get
Exactly.
entered in.
When they come in through admissions, yes, exactly.
What
just-
happens if they come in through the ER? Is that what yours difference?
Basically, there is a system also in the emergency room.
Okay, okay.
Exactly. Because their computer system is a little different than the normal
main
hospital.
hospital,
Right,
right,
exactly.
okay.
But yet they do employ the Pyxis dispensing system.
And off the top of my head, I can see a number of benefits. Obviously, making sure that only the appropriate people who
Right.
have access to
Access,
all those drugs,
exactly.
because unfortunately in our day and time now that can be an issue. And it also ensures that you get the right medication
Exactly.
for the right patient.
For the right patient,
Yeah.
right.
Because that can be obviously detrimental to
Right.
the patient's health if they get the wrong
Exactly.
meds.
If they have an allergy to a medicine or whatever, yeah.
Yeah, and so those are the kind of things, and I think sometimes people might get a little frustrated when they're being asked, you have allergies about all the
yeah,
questions.
I know.
But it's for their,
But it's their their overall benefit.
Right, for their safety, that we're doing that for their protection. To make sure. So the Pyxis system is pretty awesome, but what other changes have you seen in pharmacy over the years?
Basically in terms of monitoring systems that we have in place using our MedMind system.
What is that?
And basically it's a system of alerts that basically, I just said alerts. It alerts us to review certain aspects of a person's medication.
Okay.
And it can go anywhere from electrolyte imbalances, it can go to anticoagulation management, infection, in terms of is the patient on the right antibiotic, or is there a mismatch between what is actually growing on the patient and what the patient is actually on.
Okay.
And these are some of the things that Dr. Bauer, who is our infectious disease pharmacist, reviews on a daily basis. And then we in turn go ahead and take care of the mismatch, so to speak, and make sure that the patient gets on appropriate therapy for their infectious process.
While they're in the
exactly.
hospital.
Yeah, we contact the physician to let them know
Okay.
and what the most appropriate antibiotic would be based on the isolation of the organism, the MIC of the organism, and the most appropriate antibiotic for that infection. You know.
Very cool.
Yeah.
So I don't think people realize how much stuff is going on behind the scenes.
Behind the scenes, that's exactly it.
know?
Yes.
And that is important
Yes.
because when you're sick, you're just laying there in your hospital bed and making the assumption.
Yes.
And hopefully that's a good assumption that
Exactly.
everybody's taking care of you.
Right.
But like I said, you don't realize.
You don't realize all the things that are going on behind
all the different
scenes.
hands that are touching your care.
Yep.
And I think, well, obviously, we want to just rest assured, and our patients can rest assured that they are getting that best possible care because of people like yourself and your staff.
Yes.
And I think you have a pretty amazing staff.
Yes, we do. We really do. Yeah.
So how many people do we have in pharmacy?
We have about 14 pharmacists.
Wow.
That includes the director.
Uh-huh.
And as far as daily online pharmacists, we have about 10.
Okay.
Which includes myself.
Uh-huh.
And
that's your 24/7. I mean, there's folks that work nights, obviously, and weekends
we
too.
have 2 pharmacists on PMs. We have a night pharmacist as well.
Okay.
And then we have about 6 or 7, including myself and Dr. Bowers, on day shift.
Okay. Because that's the other thing. It's, again, people don't always think about that, but you do have to have someone there 24/7 because of, like you're saying, if things could happen, change
especially
for
with
patient.
our open heart unit.
Oh.
That's very, very important. I mean, their needs are tantamount.
So what kind of things, besides, I guess I'm always thinking pain meds, but there's obviously more. What other kinds of drugs would you be for the open heart?
Basically pressors, antiarrhythmics. Diuretics.
Okay. Those kind of things.
A lot of pump agents.
Okay. Those are a good thing that I want to ask you some more about. We're going to take a quick break, and when we get back, we'll talk about that.
Okay. Thank you.
Thanks. We'll be back right after these messages.
They have a medication profile of about 9 pages of medicines.
Welcome back to Your Health Matters. My guest today is Dr. Robert Tucker with the Pharmacy Department here at KRMC. Thanks for being on the show again. I really appreciate having you. And every time I do my program, I learn something new myself, so I know that my audience does as well. So we were talking before the break about the importance of the Pharmacy Department and how closely you work with our Open Heart program, which I know we're getting ready to start up again. So you talked about anticoagulants and what other things?
Pressor agents.
And what does that mean?
Medications that are used to support people's blood pressure immediately post-op.
Okay, to make sure they don't.
Right, exactly. And also in terms of fluid resuscitation, albumin administration.
So there's drugs for all of those
things. Oh, yes,
things.
exactly. The inotropes. There was just when you look at a patient who has come back from open heart surgery, they have a medication profile of about 9 pages of medicines.
9 pages?
About 9 pages.
I thought you were going to say 9 meds.
No. That's with scheduled meds, PRN meds, electrolyte replacement, fluid resuscitation.
So a lot of those are in IVs, right?
Yes,
They're not all pills.
No,
probably-
IV. IV, yes,
okay.
exactly.
Wow,
Yeah.
that's a lot, though. Oh my
Yes, it
goodness.
is, yeah.
So your job with the pharmacy, I mean, I know you touch a lot of different pieces, but you had shared with me before that you're considered an anticoagulant specialist. What does that
Right.
mean?
That means that I have more or less done special training in anticoagulation. All of our pharmacists have taken a course in anticoagulation certification through the University of Southern Indiana.
Okay.
And then you can go on and you can take the national board exam
Oh.
and get board certified in anticoagulation.
So I have to ask, anticoagulation means you don't want it to coagulate?
You don't want extra clots hanging around.
Okay,
Exactly.
so if it's someone
because they
that-
can be detrimental.
Sure,
Yeah.
but at the same time, you don't want them to bleed
You don't
out
want them to
either.
bleed. That's it. You've got to have a fine. Sometimes in
Balance.
some patients, a very fine line.
Between
Yeah.
too much and
Be
not
too
enough.
much and not enough.
Okay.
Exactly.
So how do you know?
Basically, we have tests that we do perform.
Okay.
Like people that are on the warfarin
Okay.
agent, which has been around since about 1955.
Oh, wow.
We have, the INR, the PT-INR, which we generally obtain on a daily basis.
Okay,
to
so
make
that's the
sure
blood
that
tests and
the
stuff
blood
that-
test,
okay,
right?
they're
To
laboratory.
measure a particular level of anticoagulation in the blood.
Okay.
And we generally shoot for certain levels based on what we're treating.
Okay.
And people that have valves in, we generally have levels that are a little bit higher than if we were treating someone for, say, a DVT-PE or atrial fibrillation or whatever. And so we fine-tune the patient to a particular INR.
Wow.
Yeah.
I had no idea. I was just thinking
Yeah.
of just stirring up drugs,
Yeah,
right?
yeah. And generally, I always believe in the motto, go low and go slow.
And then kind
know,
of you can work
and
up,
right,
see how they react
exactly,
to stuff.
yeah.
So does that, I mean, is there pretty quick, I don't want to say turnaround, but I mean, when you're saying go slow, so you start with a slower or lower.
A lower dose, especially after you've reviewed their medications, you've seen what their kidney status is, you see what their age is. These are some of the factors or the risk factors in terms of people who are at risk of bleeding.
Okay,
Yeah.
okay. And that's just one part.
That's just one part, right.
Because you work closely then with the physicians.
Yes, exactly.
To make sure
And
what
we
all
actually
symptoms.
do have an anticoagulation service where physicians can write on in the CPOE system, the computerized physician order entry, where it'll say pharmacy to dose. And we have about 50 medications which physicians can elect to have a pharmacist actually come in and dose their patients.
So they are, the pharmacist is the
Yes.
one that can determine what's
Determine
the best.
daily dose for
Okay.
and
Both the level and the
levels
right.
and the right dose. Exactly.
And I think you do a lot with patient education as well, right?
Yes, we do. Yes, we do. Very much so. In terms of at the time of discharge, make sure patients have been instructed on their medication, especially if it's a new medication.
Sure, that's important.
And we make sure, like, as I said, I did instruct one particular person. I generally instruct all of my patients that I put on some form of anticoagulation.
Okay.
Just to make sure, especially the newer ones, what we call the new oral anticoagulants or the novel anticoagulants.
Okay.
And there are 3 of those. And so I always like to make sure that when patients are ready to go home, that we do have them on the appropriate medication, that they are well informed of what to look for.
I was just going to say
before-
those kind of side effects to watch
what to look for and when to call the physician.
Okay.
Yeah, and then with the anticoagulants, you always have to weigh risk and benefit. The same thing with the antiplatelets in people who have stents in. You know,
Okay.
you have to always weigh that risk against the benefit. We know dual antiplatelet therapy is tantamount in patients that have stents in.
And why is that?
Basically, that's what the studies have shown.
Okay.
Rather than using one antiplatelet agent, generally dual antiplatelet therapy is preferential in terms of
Showing
keeping
better
the stent
outcomes?
outcomes. Right, exactly.
Okay. And keeps the stents from being
from
rejected? Or?
and clotting off.
Okay,
Yeah.
okay. So that
And-
goes back to being just like it was before they
Yeah,
had the stent where it
exactly.
can
Yeah,
close
then you
up.
have to go and restent them.
Right,
Yeah.
try to avoid that, obviously,
Yeah.
as much as possible.
Exactly.
But, it's, again, we go back to what I was saying before the break, how people I don't think realize, again, how much goes on behind the scenes, and then you're with them and educating them.
Right.
When they're on new drugs, I'm assuming you come in and
Yes,
talk to them as
very
well?
much so, yes.
And again, I guess it's the important understanding why they're having to
why
take.
they were placed on this particular medication.
Yeah. Now, with the anticoagulants, and I don't want to just spend time just
Right,
on that,
right.
obviously, but what are the types of side effects a person would have with that? If
Basically, the biggest thing that we worry about is excessive bleeding.
okay, so
And
bruises
yeah,
would be
bruising, when you brush your teeth, are you
gums are
bleeding,
good,
the gums, etc. Nosebleeds.
Okay.
When you urinate, is there blood in the urine?
Yeah, okay.
When you defecate,
Okay.
is the
blood
stool?
in the stool, yeah. Okay, so those are the kind of things you have to watch for.
Yeah.
And then if they have those symptoms, then do you just change their dosage to?
Basically, I always ask them to check with their physician.
Oh, okay.
That is probably tantamount for making sure that the physician is always in the loop.
Sure.
Yeah.
But I would think you also play an important role because you so closely monitor the patient and look at what they're on or have been on in their history.
And if they're on a particular medication that is going to possibly interact, say it's an antibiotic or whether it's a statin lowering agent, basically I would try to switch them to one that would be safer.
Okay.
Yeah.
Because then I would think you also then work closely with the physician to make sure if they're on more than one kind of meds that they're not going to interfere with each other, right? Because we always have to be aware of that as well. That sometimes those meds can counteract.
Right, that's it.
Right, is that, I don't know if I'm.
That's what we call the cytochrome P450 system, where basically there are certain enzymes which have a propensity to interact. Yeah, and so we always look to make sure that the patients could be switched. If they are on one of those interacting meds, they could be switched to something that would not interact with a major medication like an anticoagulant.
Awesome.
Yeah.
So we talked again before the break, the first part of the show, about how much you've seen change in your years in pharmacy. Almost 50 years now.
Oh my God.
I know. Oh my goodness.
I don't look it, but I.
No, you don't. You don't. But there had to. I mean, so you started out doing more manual, and now everything is so computerized.
Computerized, automated, even making parenteral nutrition with the newer machines, et cetera, and the pump delivery systems for medications, et cetera.
It's so much more.
It is, exactly.
Automated, which I think more efficient, more effective, obviously. I mean, there's reasons we've gone to all of that.
Exactly.
Patient safety, I think,
Patient
number
safety.
one. I think another thing we want to maybe mention, too, is our new barcoding system.
Barcoding, yes, we do barcode the medications. The nurses do actually barcode. They have a little adapter, and they
like a reader?
Like a reader, exactly, and they basically make sure that everything matches up.
So when the patient's
and they go into the patient's room, right?
They have
and
a wristband with the
barcode,
or barcode, and that matches then what they're
right,
nice.
Exactly.
So again, that's all of these things we have in place. To avoid issues.
Patient safety.
Patient safety is number one. That's amazing. Now you talked about. Did you say 19 pharmacists that we have?
We have a total of 14.
14, okay. 14 pharmacists. And then you have support staff as well,
Yeah, we
right?
have pharmacy technicians.
Okay.
We have 2 senior or lead technicians.
Okay.
And then we have our regular staff, pharmacy techs, on all 3 shifts.
Wow,
You know.
that's a lot of people then. It is a big.
I think the whole department, when I was reviewing the pharmacy survey, it said we have a total of 34 in the pharmacy department. So I would say maybe there might be a few more than 14 pharmacists.
Yeah, that
But
sounds
I
like
think we've got around 14 or 15. And I believe that includes myself,
Sure.
the
director.
Ray, and Bruce.
Right. So what is the difference, or what is, well, I'm sure it's a matter of levels or number of years of education, but between a pharmacist and a pharmacist technician, you mentioned.
A pharmacist technician is basically approximately 2 years of schooling at a neighborhood junior college.
Okay.
And then you can go and take a PCTB exam, which is PTCB exam, excuse me.
And that's-
and that's what actually certifies them as like a licensed technician.
And what kind of things do they do different than you?
Basically, they do a lot of the preparations
Okay.
of medication, whether it be sterile, non-sterile packaging, whether it be preparing things in syringes,
Okay, and
making
dosages,
chemo,
making sure.
making TPNs,
Oh, we didn't even
things
talk
like
about
that.
chemo.
Yeah.
That's another whole
Yeah.
aspect of
Yeah.
it. I didn't even think about that.
Yeah.
And we're almost done with the show, so we may have to have you come
That's
back another
exactly
time
right.
and talk about those kind
Exactly.
of things. Because
Yeah.
every department probably almost has different specialties.
Yeah. And we do have a pharmacist that specializes in chemo,
Okay, good.
and she does that Monday through Friday.
Okay, well, maybe we'll
Yeah.
have to have her come on the
Yeah,
program.
exactly.
Our time's already
Okay.
up, but thank you so much
Thank
for
you for
being on
having
the
me.
show. I
Yeah.
hope you learned something new today. I know I did. We'll see you again next week with another great guest.